So as people are coming in, I just want to welcome everyone. Welcome to our panel and discussion on the intersection of healthcare and domestic violence. So we are the COVID-19 Task Force on Domestic Violence, and this is actually our sixth series in our seminar series focused on educating and discussing domestic violence during this time. We are so thankful that you guys are tuning in, and it would be great to get a sense of who is here. And so if you could just introduce yourself in the chat box with your name, your pronouns, and where you're watching the seminar from, that would be awesome. And also if you have any questions you want to ask, just please put it in, and there's a space later for us to sort of answer questions the participants.
Great, and we're so thankful you've joined us today. We wanted to take a moment at the beginning of this to talk about what is going on in our country today and what has gone on for quite some time. So as an organization committed to strengthening our community against domestic violence, it's important for us to recognize that many of the survivors that we are hoping to help are POC generally, and specifically Black, and many of the allies that we are hoping to enable will have a role to play in the generations overdue healing that our country needs. And we also wanted to take the time to recognize that today is Breonna Taylor's birthday. Breonna, who was killed by Louisville police in March, would have celebrated her 27th birthday today. And this time is a challenging and exhausting one, one that puts quite a burden on folks to do this work, often the same folks who are victimized. So we want to say thank you to the panelists for showing up. Thank you to all of you in the audience for showing up. Thank you for those who show up every day. And we wanted to say that we are recording this call for people who have expressed interest but felt like they weren't able to show up today. So if you're not comfortable, please feel free to reach out to us. But just wanted to say again, thank you. So I'm gonna go ahead and start off with introductions. My name is Catherine Zhang. I take the pronouns she, her, hers. I graduated from Harvard with a degree in psychology and educational studies. I'm calling in from Pittsburgh right now after having taught English in Taiwan on a Fulbright this past year. And next year I'll be teaching in Boston, as well as earning my master's at the Harvard Graduate School of Education.
And I'm Ina. I am co-hosting with Kat today. So I also graduated from Harvard College in the same year. I was pre-med and I studied history of science. I'm from Boston. I take she, her, hers. And this year I was at the University of Cambridge to study a master's in health, medicine, and society. So sort of continuing on my history of medicine background. And I am going back to Harvard for a MD PhD, where I'll be doing my PhD in history of science. And so we are just so excited to welcome all of you. And just again, I mentioned earlier, for the people that are coming in, it would be great to know where you're coming from, your pronouns, and if you have any questions. So that's what everyone's adding into the little group chat right now.
Yeah, and so just to give a sense of this organization, we're part of the COVID-19 Task Force on Domestic Violence. I know there will be more information in the chat about our organization, so please check it out for more information, but we would love to get to introducing our panelists.
Yeah, so we are honored to be moderating this discussion with three incredible panelists, each of whom are from different expertise, and they have different insights and reflections. And I'm going to give a quick introduction by reading their bios. So we have Dr. Uju Berry, who is an MD, MPH, and there she is. And she's a graduate of Harvard Medical School, the Johns Hopkins Bloomberg School of Public Health, and Columbia University Psychiatry Residency and Fellowship programs. She is an academic researcher and clinician with clinical expertise in early childhood mental health and reproductive psychiatry. She is experienced in mental health research, public policy, and has worked with a variety of state and federal institutions, including the Centers for Disease Control and Prevention, the U.S. Department of Health and Human Services, and the National Institute of Domestic Violence in the African American community. During her training, she has led a citywide hybrid implementation effectiveness study on the evaluation of a mental health and intimate partner violence intervention with New York City's mayor's office to end domestic and gender-based violence. Dr. Berry's research focuses on implementation science, intergenerational transmission, and impact of trauma on child psychopathology. Starting in July, she'll be transitioning to her new role as medical director of at H+H Behavioral Health and Domestic and Gender-Based Violence Collaboration as an assistant professor at NYU with the Department of Child Adolescent Psychiatry.
Hello, everyone.
We're so happy you're here with us today, Dr. Berry. Our second panelist is Diya, if you want to give a wave. She's the Director of Training at the Victims of Violence Program at Cambridge Health Alliance and the Trauma Consultant for the Department of Psychiatry. She's an assistant professor in the Department of Psychiatry at Harvard Medical School. Her clinical specialty is in the treatment of trauma-related disorders. She's a member of the Task Force for Human Rights of the American Psychological Association and has published in the areas of complex trauma, gender-based violence, homicide, bereavement, and refugee health. She's the co-author of the Trauma Recovery Group, published by Guilford Press, and the Trauma Information Group, published by Guilford in 2019. We're so happy you're here with us.
Hi, everyone. Glad to be here.
And our third panelist is Robert Sege. He is an MD, PhD. If you can give a wave, Dr. Sege. Awesome. So he is a pediatrician at the Floating Hospital for Children at Tufts Medical Center and a professor of medicine at Tufts University School of Medicine, where he directs the Center for Community Engaged Medicine. Dr. Sege is nationally known for his research on effective health systems approaches that directly address the social determinants of health. He is a senior fellow at the Center for the Study of Social Policy in Washington and serves on the boards of the Massachusetts Children's Trust and Prevent Child Abuse America. He has served on the American Academy of Pediatrics Committee on Child Abuse and Neglect and on its Committee of Injury, Violence, and Poison Prevention. He's a graduate of Yale College and received his PhD in biology from MIT and his MD from Harvard Medical School. Bob lives in the Boston area, where he and his wife Karen have raised 3 young adult children.
Thank you. It's really delightful to be here. I'm looking forward to a wonderful conversation.
So let's get to the conversation. And the first question we wanted to pose is a general one because it's been on the minds of many people, which is, has domestic violence increased during this pandemic? And because there are conflicting reports and the data is hard to collect, we wanted to speak to you three, particularly because you are at the front lines and we want to hear your experience. So I don't know, Diya, maybe if you want to start, and then Dr. Sege, Dr. Berry, feel free to follow up.
Thanks, Kat. Glad to start. I want to start with just saying, which I'm sure my esteemed colleagues well know, that domestic violence was a global pandemic much prior to COVID-19. And there have been, the data is far from equivocal, but there have been several reports of increased domestic violence in this context. I think for all the reasons we can imagine, increased, people stuck in violent homes, hoarding of alcohol and guns, scarcity of community resources, shelters feeling overtaxed by the fear of COVID-19. What we're seeing clinically to balance out the data, that I think the UN Population Fund put out a study saying that they're expecting a 20-fold increase in domestic violence reports. What we're seeing on the clinical side was during the first surge in Boston, as we're preparing for the next one, there was an eerie kind of silence, I would say. Much fewer presentations to the emergency room and inpatient settings, much fewer calls to our trauma clinic. And as the medical pandemic is slightly waning, we are now seeing a huge increase in people asking for help and looking for beds and looking for shelters. So I think it's what we would expect, but I would describe the silence in the first few weeks as eerie and very unnerving.
Yeah, I just want to echo what Diya had mentioned, that you're absolutely right. I mean, before COVID, domestic violence and gender-based violence was a pandemic. I mean, the WHO called it a worldwide epidemic of epidemic proportions. So it was there. I mean, with our national population-based surveys, it was 1 in 3 women and 1 in 4 men had reported rates of intimate partner violence across their lifetime. I think what we're seeing with COVID is that, and this has been similarly reported during prior disasters, like after Hurricane Katrina, after the Ebola virus, after SARS, there's always tends to be a rise in the rates and reports of intimate partner violence, much to what Diya had talked about. I mean, the risk factors that go along with intimate partner violence tends to be centered around stressful situations, and COVID-19 is definitely a very stressful situation, not only with the virus, but because of the public health response put on top of it, where people are losing jobs, not having economic security, having housing instability. And then on top of that, you know, what we're also seeing is that they're quarantining their homes with their abusers, but they're also taking on multiple roles, which can also be very stressful in itself, having to be the parent, the child, the primary caregiver, if somebody older or younger, and going to work or not going to work. It's very, very troubling. I think in terms of what we're seeing, the reports, I think really what's happening is that, and I don't know why it's taken this long, is that the way we're capturing the data is just not very accurate. It had never been really accurate. And when you think about communities of color, reporting it to the police, which is how most people gather data, has never really been something that people of color felt comfortable doing. You know, there have been studies in the past where people of color, especially Black communities, tend to go to informal support groups like friends or families or community elders to report DV, and not necessarily to the formal processes, which is police. And just given what's happening right now, it makes perfect sense why that would be the case. And so I think COVID is really just highlighting that even though we're seeing a decrease, it's really because we're just not capturing the data accurately. And so there needs to be a better way of capturing. It may not be to the police, but you know, another way people are thinking about it in New York City, which has been the epicenter, what we're seeing is that there have been higher rates of people calling into the hotlines, higher rates of people actually going to our the statewide website on DV in New York State. There have been a lot more clicks on that, which may not be an accurate representation either, but it's something to showcase that people are thinking about it as well. And I think all of what really, really need to understand is that we just need a better way of capturing the data, and it just doesn't really reflect it.
Yeah, I just want to echo what Uju just said, which is that the data really is pretty dismal because reports on domestic violence, including all kinds of family violence like child abuse, are a very inaccurate reflection of what actually happens. And we know in the case of child abuse, for example, that less than half of the cases are reported, and that there's a racial bias in reporting. It's a pretty dramatic racial bias, which probably serves Black families poorly and certainly serves white children poorly. It's a very complicated thing to understand how all this works. I think that one of the issues is we actually don't know what's going on. The number of reports has been down. It's possible that families are less stressed. Certainly in the case of children, there may be more adults at home, and kids cry, they whine, they do all kinds of things. And we know that crying is one of the leading precipitants of child abuse. So not sure. And then some families have essentially taken this as summer vacation time a little bit early. So we've heard stories from the Bronx and from all around of families who have gotten unemployment insurance and cannot work using this time, and the family's actually getting stronger. My concern, and it certainly agree with the other panelists, is that what's really going on though is that children are not seeing their relatives, their parents, their early child educators, their school teachers, who typically detect and report child maltreatment. So it could be an artifact. But good news today, we just got notified by the CDC that we'll be doing a family survey together with the American Academy of Pediatrics and Prevent Child Abuse America, that we'll start doing it hopefully soon and repeatedly over the next 6 or 8 months to try to find out on a telephone survey basis what's happening at home. So a different way to find out what's going on.
Related to that, one of the questions, Dr. Sege, that I wanted to ask you was, since a lot of your work has been related to adverse childhood experiences, and you work to combat that with increasing the number of positive experiences, I was wondering if you can speak to that a little bit. And are there opportunities here for more parents to create those positive experiences now that they're home, or do you see those sort of there's too many issues going on?
No, just to answer the second question first, there definitely are opportunities for parents to create more positive childhood experiences during this period. Kids don't actually read the newspaper very much, so they don't know about the overall situation. They're very concerned about what's happening at home. So we've heard about various parents doing creative things. One child may be camping out in the backyard for a family. Other children, particularly teenagers, have found ways to get engaged in their community, delivering food, delivering messages, all kinds of things. I think that there's a large number of children whose memories will be of a terrible time in this country, but also how they were engaged with their community or with their parents, how they reached out by FaceTime or whatever way to their elders who couldn't get out because of their risk of disease. So it's going to be a mixed bag. And our group, you can look at positiveexperience.org, has really been talking with parents about how to create positive memories in this really dismal time, because children experience things differently. Having said that, the way we got into this is that much of what we're trained to do as professionals is to identify problems, identify risk factors, and then treat them. And that's not a bad thing, but in some areas it can be very destructive. So our group is looking at healthy outcomes from positive experiences. And partly it's a reaction to the adverse childhood experience study that showed that children who had been abused or neglected or had family dysfunction are at higher risk for adult disease. And then there's been a movement around the country to assess people's prior adverse childhood experiences and give them a score, which is a number from 0 to 9. And one of the issues with doing this is the score belongs to you. It's your own personal thing, but at the same time, it can pathologize social dysfunction. So Wendy Ellis at Georgetown has done a wonderful job of putting together what some of the societal factors associated with childhood adversity are. You know, and one of them, it's almost trivial but sad, is that one adverse childhood experience is having a family member incarcerated. And it's obvious to all of us that Black men are incarcerated at far higher rates than anyone else. So Black children are more likely to have that adverse experience. And we don't think that pathologizing social problems really is very helpful. So we've been focusing on what things parents can do, but beyond parents, how we create a society where children have a safe, stable, secure, and equitable environment to live, learn, and play. And all of these factors really come in. It's important to remember that we all think that parenting is important, but parents operate in an environment that's surrounded by their own community, and that in turn lives in a larger culture. And the issues that have kind of hit us over the head over the past few weeks really show that the larger society can be cruel to some families.
Absolutely. And Dr. Berry, I'd love for you to jump off of that, of your own work as a child and adolescent psychiatrist. Do you echo the same things that Dr. Sege had mentioned and want to add?
Oh, absolutely. And I think, you know, Dr. Sege actually did a great job just kind of constructing the overview of it. I just wanted to highlight a few things that the medical, so this is a topic about healthcare and domestic violence, but the medical model really works on a product of deficit. You know, people go to the hospital, people talk to their clinicians and their doctors because something's wrong. And I think when that's the case, it really takes away from the opportunity of positive experiences that Dr. Sege has talked about, or resilience factors. And I do think there's something for the medical establishment to do, which is really think about more kind of primary prevention. Like, what are ways we can utilize as a whole, as a public health institution, to kind of prevent disasters or distress from happening in the first place? And one of those is talking about parenting. You know, it's very interesting when you think about just public health initiatives. Like the fact that, you know, in order to drive a car, you have to take training. in order to become a social worker, you have to take training. There's always trainings involved, but no one gets trained in how to be a parent. And it's not always intuitive. And oftentimes what we are taught is what we know from the past. And some of those past experiences may not be the best. But we do know that positive experiences can be really, really golden. And it's not that much work. It could really just be like a simple acknowledgement to your child and looking them in the eyes and say, I see you, I hear you, I'm here for you. That's like maybe 5 seconds, but people don't view that as a type of treatment. And it can be a treatment. And I think the problem is that people don't view it as a treatment because it's a positive as opposed to a negative, and the medical model operates on a negative paradigm. And so I grew, and people talk about disasters and as being terrible things, but sometimes you can really view it as an opposite way, that sometimes disasters like COVID really kind of open up in the chasms that really need to be fixed. And that's an opportunity for us to really think about what can we do to kind of change the system. And one of those is to kind of talk to parents and saying, like, you are much closer to by physically being closer to your kid and seeing them 24/7, you have multiple opportunities for those little brief interactions that really can be a buffer through multiple different studies that Dr. Sege had mentioned, has shown to be really helpful in preventing adverse childhood experiences. And also just being, helping people grow to be healthy adults. And it's really important because I think, in my practice, I see children, but I also see parents and new parents, during COVID, one of the biggest topics that people talk about is, what do I do with my kid? How do I treat my kid? My kid's like going off the rails, I don't know what to do, I'm trying to work. And I think it's really kind of reframing the narrative. I think very, very beginning, people were like, oh, I need to be able to sit my kid in front of the Zoom for 5 hours and teach them and make sure that they're doing all their homework, where in reality, this might be just an opportunity, as Dr. Sege mentioned, to have kids view this as a memorable experience where they got to really partake in the family and the community as a whole.
Absolutely. And Diya, we were wondering if you have any reflections on what Dr. Sege and Dr. Berry just said before we sort of shift the focus a little bit to focus specifically on the racial dimensions of COVID-19 and domestic violence. But I just wanted to give you space to reflect.
Thank you. I think you both expressed it so beautifully. All the different dimensions of both the vulnerability, but also the resilience we see with families. And I think as they both spoken to so powerfully, I think there's the presence of some things and then there's the absence of others. And I think they're trying to call attention to both of those dynamics. So for example, the presence of abuse, but also the absence of parenting, that, I think abuse really cannot exist without neglect. And so I think they're calling attention to both of those pieces that I think, as I think Dr. Berry said, and Dr. Sege as well, that the pathology gets more attention rather than other things that could, to some degree, mitigate the effects of those things.
Right. Thank you so much for that. So one of the things that has been coming up in conversation around COVID-19 is that it's obviously been affecting different communities disproportionately. And recently, in light of the current events, we've been speaking to domestic violence organizations specifically about Black communities. And Dr. Berry, you just mentioned this as well, but organizations have said that specifically a lot of Black women are experiencing domestic violence, or their kids are afraid of calling the police because they're scared that it would cause excessive repercussions, but they might feel more comfortable with talking to healthcare providers. So Diya, when we spoke last, you had mentioned seeing different communities being affected disproportionately, and we were wondering if you could speak to what those differences are and what's been done to sort of address them. And Dr. Sege and Dr. Berry, please jump in whenever, because we want this to be a starting point for this broader conversation.
Sure, and if you'll all indulge me, I'll just sort of give some context to the hospital and the population we serve, because I think that will help to illuminate some of the issues. So Cambridge Health Alliance is the last remaining public hospital in the Boston area, and we have to serve the poor, the sick, chronically mentally ill. As a result, vulnerable population, that's our mission. And we see people who have racism and classism as along with intergenerational mental health issues and trauma transmission. In that context, we serve a large immigrant community as well. And what we're seeing is that each community is getting, because of the immigration patterns to Boston, is getting affected, and the disproportionate impact, as you referred to, is we are seeing that in every possible way. For example, in Boston, we have a large Haitian community, as I'm sure Dr. Sege knows. We have the largest population outside of Florida and New York. And that we are seeing on our Haitian team, we have a mental health team dedicated to that population. We are seeing both the burden of COVID-19 in terms of morbidity and mortality. We had one patient who lost 7 members of her family to COVID-19. Unfortunately, represent clubs very much at risk for contracting COVID. And then treatment in the health system fueled by attacks of prejudice. So that's one example. We also have a population dedicated to the Asian American community, and that team is seeing much higher reports of racial and racist acts and discrimination, significant rules around immigration. Our team that serves our Latinx population is also seeing a significant disproportionate impact on job loss, on lack of access to health benefits, on prolonged separations from their families, not knowing when they will see them again. Living in multi-generational homes where the transmission is significant. So I could go on. And I think that we are really aware of this as a health system. I think what happens when you treat a vulnerable population, our health system is quite vulnerable as well. And suffers from everything that comes from lack of resources that are dedicated to hospitals that serve the poor. We are having these conversations on an institutional level, so that I think the discussion we had, for example, on Wednesday at the leadership level was, are we in fact working to reduce disparities of care, or are we in fact unconsciously or unwittingly or perhaps wittingly contributing to them by not making this, by having these teams siloed into this group that treats this group, and rather than seeing this as our majority of our patient population. So those are the kinds of conversations being had, and we are hoping to distribute resources to the teams where they are seeing this kind of impact, as well as various other social justice efforts. And we have had a mission to become a trauma-informed organization for a long time, and we are trying to implement that in both institutional ways, in terms of retention of employees, and in terms of our advocacy around vulnerable groups, in terms of even very specific things like PPE, because there has been certainly a lot of inequity in how those things have been distributed at the hospital as well. So I'll pause there, and I would love to hear what Dr. Berry and Dr. Sege have to say.
Yeah, Diya, I really appreciate what you said, particularly about the Haitian community, because I worked at Boston Medical Center for many years and got to really understand some of the issues affecting Haitians and other immigrants. And if you think about who's at the highest risk in our healthcare system, for example, it's actually not the doctors and nurses at big hospitals. It's often the personal care attendants, the health aides, the medical assistants who work at smaller places or provide home health services. That's just one example of how disproportionately exposed some people are to COVID, and consequently some of the statistics we see. And what you said about the toll in the Haitian community makes me very sad, and also understand how all of the divisions in our society are really coming into play, so that the people who are at the lowest paid, do the hardest work, are the least likely to have the protective equipment they need to stay safe.
Yeah, no, thank you both, Dr. Sege and Diya. That was a great overview of what's been going on. And these health inequities, again, like DV is not new, it's just there. COVID just has really kind of exposed those fault lines. And I think also journalists and social media and people are bringing it more to attention. So I'm currently in New York City, which is the epicenter of COVID within the United States. And, during the acute surge from March to April, it was really, really dismal. And it wasn't a recent realized that there was disproportionate effects of COVID-19. And mostly, again, when we talk about data, it's because the data just needed to be disaggregated. Until we did that and actually looked at by racial, ethnic, and socioeconomic factors, we didn't realize that. But it was present from day one, you could see it. And I think, so we could think about it from a patient population level, but then also you mentioned like the institution level too, which I also think is very, some of the disproportionality as well. Within New York City, we have Health and Hospitals, which is one of the largest public hospital systems in the country, but they were the ones that were most heavily hit by COVID, not only in terms of the number of patients who went to them, which were mostly lower socioeconomic, racial, and marginalized communities, but they were most heavily hit by the number of healthcare workers who also got sick. They're mostly hit by the fact they just didn't have access to PPE or didn't have access to workers who could fill in. Whereas you contrast it to some of the private hospitals, which are also large, they weren't heavily hit. And the fact of the matter is they're maybe like 3 miles apart. And so it really just kind of speaks to like not only on the patient level, but also the hospital level too. There is a disproportionality that also needs to be addressed. And I think it really needs to start from the top.
That's such a good point, is that there's the institutional level all the way down to the patient level, and thinking about COVID-19 particularly has exposed a lot of these fault lines, like you mentioned, Dr. Berry. And I think something else that we've been seeing has also been, because COVID-19 is asking people to stay at home, telemedicine has increased a lot more. And so I would be interested in hearing all of your thoughts on this, particularly how it's disproportionately affected people, whether there's pros and cons to telemedicine. So I don't know if Dr. Berry, Diya, you'd be able to speak to it within your practice, but also I know Dr. Sege, you have been working with the AAP to discuss telemedicine and family violence for pediatricians around the country. So if you want to start, and then Dr. Berry and Diya, you can follow.
Great. I can just start with some general comments, because we've been worried about this at the American Academy of Pediatrics, and they have a series of 50-some small groups of pediatricians, around 30 or so, around the country, that have been meeting via Zoom to discuss the response to COVID. And I and my colleagues each led sessions with these groups around child abuse detection and prevention. And the issue for telehealth is that you don't really know who's not in front of the camera, but behind the camera. So there are opportunities that you might have with a person in private when it's just the doctor and the patient. And even with teenagers, we'll often get a chance to talk with them alone, parents, and to find out a little more about what's going on. Those opportunities are essentially lost. So the suggestion that we made, and it's I just want to say I don't think it's a perfect solution, is to ask the pediatricians in every encounter that they have with families to tell the older children and teenagers how to get in touch with them directly if they need to have a private conversation, so that they can answer it. And they usually have ways of phrasing it, and sometimes it needs to be text or via the net, because they may not have privacy to speak freely while they're at home with their parents. So this is kind of a big worry. We do talk about it, and we also, of course, provide guidance on what to look for when you do see babies and children on video, what kind of bruises they might see. But we know that that's not very likely to detect child abuse and domestic violence. It's hard. Pediatricians around the country routinely screen for domestic violence. We ask moms and dads about the situation at home. We're connected with resources when there is family violence. And because we have long-term relationships with many of our families, many families can get connected to resources for domestic violence through their child's pediatrician. And we're just concerned that's not happening now because the person on the phone may not have privacy to speak about it.
Yeah, I mean, there are many trade-offs with telemedicine. And, I was thinking about it too, and I was jotting down some notes. Just again, from the institutional level, from the patient level, how it's affecting our work, how it also affects how you have to be creative in trying to do the work that you're trying to do. So from an institutional level, so I actually kind of straddle two different systems, and those two different systems have enacted telemedicine very, very differently. So I work at Columbia, but then I'm also transitioning to H&H, which is the city's public hospital system. But Columbia, it was like within the next day, they said, everybody's going to do telehealth. And so we were all told to work remotely. All the healthcare workers, essential workers were told to work remotely. And we had access to telehealth. Those were embedded within our electronic medical record system. We had phones that could do it. And so it was a very easily seamless transition. However, with H&H, with a public city hospital, due to a lot of bureaucracy, but also governmental institutions and policies, the healthcare workers were not allowed to work remotely. They had to actually go to hospital and use the hospital computers to do the remote work themselves. And even then, it took about 3 to 4 weeks for it to have AV features. So people were actually doing sessions just via the phone. So you couldn't actually see the patient or the client. And again, it speaks to that disproportionality and disparities within the healthcare systems, that there are some institutions that are just much more nimble and have the money and resources to enact something that's very, very helpful. And there's some institutions that don't. And the ones that don't tend to be ones that serve the poor communities and are affected by that. In terms of the clients, again, there's also disproportionality as well. There's some clients who have the latest iPhone or latest Android and can have the greatest data plan where they can do the AV equipment. And there's some clients who just don't. And so most of these sessions have to be by phone, or they don't really have the knowledge or know-how to be able to use the phone system or the AV system and have to recruit like a family member to do so, or take their kid's iPad or what have you. And that can also affect things. In addition, there are multiple different platforms for telemedicine. So right now we're using Zoom, which tends to be one of the more user-friendly ones, but the H&H public system, they actually require to use WebEx, which is less user-friendly, and that can also affect the patient-client relationship. And then going to what Dr. Sege talked about in terms of privacy, I think, when a patient or client comes into your office, you can almost guarantee privacy. You can close the door, ask them to leave. You don't really have that ability as much with telemedicine. You can ask and encourage your client or patient to go to a closed room, but sometimes, especially in New York City, with small condos, like families living in a one-bedroom condo, it's not feasible to do so. And so therefore it requires a lot of creativity about how do you assess confidentiality and privacy and risk assessment, and enacting code words. So some of my clients and I, we have a code word that we use when they can just stay and when they're not feeling safe, and that could be an opportunity for us to really kind of change the system. But even just assessing for like suicidality, if somebody were to say that they're imminently suicidal, and before COVID and in my office, I could then do risk assessment and make sure they get to the proper channels. But if they're at home, I have to rely on somebody else to kind of take on that role. And so it really does change the dynamic as well. And then the other thing I was thinking about too, I think it really, there's something about like Zoom fatigue. I'm not sure if that's a term that people have heard about, but being on Zoom all the time is really, really tiring and exhausting, and it requires a lot of different mental resources to be able to do that and connect with your patients or clients. And that's something that we're not necessarily taught about, and especially when you're trying to do group sessions. In psychiatry and psychology, we tend to do group therapies, and that's a whole different way of doing it on Zoom. And a different platform than just in an in-person setting. But again, one of the positive things is that I'm seeing that it's easier for me to reach out to my clients. There have been, in psychiatry and behavioral health, usually there is like a 30% no-show rate. There's no no-show rate. Everyone comes. And I think it's because the logistical difficulties of hopping into the subway and walking in 30 minutes to get to your therapist's office is no longer there. You just turn on your phone and there you are. And so there's no, it just lends to a lot more frequency of usage and a lot more easy of usage of being seen by your therapist as well.
Uju, when I was listening to you, I was really struck by how your comments about the two different systems reflect directly what systemic racism is. Because it's not that when you worked at Columbia, you were a racist, and when you worked somewhere else, you weren't. It was that because of a long history of racism and all kinds of issues, the systems are set up so they don't require people to be biased for the results to be biased. It's a really important lesson, and that's why we have to disassemble our systems and reassemble them, because if we just think about improving our understanding or raising our consciousness or being aware of implicit bias, it doesn't get you where you need to be, because so much of everything you said is really just baked into the system of care in New York it doesn't require individuals to be bad in any way. It just is.
Yeah, absolutely.
Thank you both. I think those are such incredibly illuminating comments, and I agree with you, Dr. Berry. No more no-shows. That's definitely been our experience. I think just to jump off both of your comments, I think telemedicine has the opportunity to reduce disparities in some ways. I think there's the hope for that. As you were saying, people who had transportation difficulties or logistics or had to work 3 jobs certainly access psychiatric care at our hospital at lower rates, or overrepresented, or in the emergency room or acute service. So I think to some degree, there has been some capacity to reach out and have access for more people. I think things like partial hospitalizations, different levels of care that other people couldn't access, now that they're being done by phone and video, people can do those more. But as you both have said, I think it also has reinforced other disparities. Patients who live in crowded homes, have bad internet, share phones, share computers. I've done many, many sessions with patients in their cars, walking around, and the privacy implications, of course. So I think all of that is, part of this picture. I wanted to just add a couple of things, and I think to both your points about the institutional, I was sort of smiling to myself when you were talking about the Columbia versus NYU or HHS. Our hospital suddenly being probably closer to HHS, usually to get anything to happen, it's like moving an aircraft carrier while it's in motion. I mean, it takes, 10 years to get a new light bulb for your office, and I'm not even joking. I just had to go get it myself from Target at some point. So I think that, but for all of that, our system actually moved quite rapidly to provide access to our most vulnerable population. But what we did see was this inequity in staffs and who got permission to work from home and who had to go in to cover the acute services, especially in psychiatry. And those workers are often paid less, overrepresented by people of color. And I think that it really exposed who had the privilege to work from home and who had no choice but to go in, even if they were exposing themselves and their families to COVID with initially inadequate PPE. The other thing I would just wanted to say is that our hospital is also the public health system for the city of Cambridge. And as part of our mission to be trauma informed, we offer a lot of secondary trauma or sort of debriefings to our communities and our cities that we serve. So for some constituents, for example, we recently did one for the nurses who worked in our ICU. We did some for the nursing home staff with which we are affiliated, who, as you all know, our extremely impacted by COVID. And in hearing that, I think to Dr. Sege's point earlier, we are doing some for the city for teachers and for language liaisons who help our immigrant kids integrate into the schools. They are now in people's homes in a way that they never planned to be or never expected to be, and are witnessing both positives but also exposed to potentially really troubling situations. And they are a pretty traumatized group at this point. Just the helplessness that they feel, their inability to be there in person. And so we are really seeing more and more requests for those kinds of workshops for frontline staff who are now in people's homes, so to speak, and have, very limited access to what to do. Our own Child Protective Services, for example, in Massachusetts is called DCF. I had recently had to deal with them, and they were saying, now they do home inspections, for example, and they're doing them on video, and just imagine, I mean, it's better than nothing, certainly, but it really, even when you have to call in emergency services, how hamstrung they are in their efforts to intervene.
So we know there's a few participant questions, but we wanted to ask one last question before we move into the participant questions. Sort of following what Diya just said in regards to resources for healthcare providers. One thing that the task force has been working on right now, and Dr. Berry has been really helpful with it, is that we're trying to create a survey for healthcare providers and asking them whether or not they are comfortable in asking patients if they're experiencing domestic violence or abuse at home. And as we just had a conversation about, there's a lot of reasons why there's just a lot of issues in that, whether, not sure if the patient is completely, alone. But one thing we found was that a lot of healthcare providers want to know what to do next if, say, a patient does test positive, quote unquote. And Diya, I know you just mentioned for resources like workshops or healthcare providers, but I was wondering if Dr. Berry, you had anything to add to that, whether it's resources for healthcare providers to know how to ask these questions, or even what was just mentioned is how to take care of yourself during this time when you feel so hopeless, where you might know your patient is suffering from domestic violence, but you can't do anything. You can't bring them directly to like a social worker that can help with it. So I was wondering what those resources are and if they exist.
Yeah, no, absolutely. I think, you kind of hit on a couple different points too that I want to bring up about what it means for healthcare workers to inquire or ask or assist or screen for domestic violence in their setting. And, as a healthcare provider and, a physician or a social worker or what have you, we go through training. And part of that training is the idea that you are presented with knowledge, and then you know what to do with that knowledge. So for example, it's very easy to go through medical school and, have somebody come into the emergency room and say, I have a cough. And then you go through the different differentials and you figure out what you need to do next. And then you're done and you feel good about it because you did your job. I think with asking and trying to assist with DV, it's not the same, mostly because we just don't get enough training. I think in multiple different education levels, we just don't get enough training about what DV is, how it affects populations, how it affects individuals, but also how it affects you as a health provider to ask about it. And then therefore, we don't know what to do, what's the next step. And mostly because it's an intersection of medicine, but also society and social work. And I think the medical system hasn't really done a good job of having that liaison with communities, unless you go into a community organization like Cambridge or something like that. But most of the time, it's not the same. And so there's definitely a lack of training. But I think the other piece too is that people view asking those questions as very personal, and there's not enough training about what that means for the healthcare provider to take on that information. I was just talking to a colleague who was like, who's an emergency medicine physician, and he says, it's very easy for me to excise a pilonidal cyst, which is like a cyst that can form like in the armpit, but sometimes in the buttocks, and it's like gross with abscess and gunk, and you just like excise it and then it spews out and it's disgusting. And he says, like, it's very easy for me to do that, but it's really hard for me to ask about DV. And he's like, because I just got training. I knew that like once I did this, the patient was going to get better and they're going to move on. But with DV, if I ask a question and connect them to the social worker or community organization, I don't know what's going to happen. And I have to sit with that. And that can be pretty hard for our staff to do, especially if there's not a system in place for people to process that information about, like, I just went through this, I just heard this horrible information, what do they do? There's no opportunity for that in medicine. Oftentimes it's like you're on to the next person. And that can really affect the healthcare system and people wanting to help out. So there are multiple different ways that the healthcare system can help our trainees understand how to really help with survivors.
Uju, I love what you just said, Dr. Berry, but I want just to add another little twist to it, and that is that the agency of the person who we're asking the question to. So if you think about cancer, right? Like, I want to know if I have cancer. I have this belief that if my doctor found something, it would be better than if he didn't find it, and I might get cured. And my doctor probably has had patients with whom he's detected cancer who died anyway. But he can live with that, and we're allies. But when you go in with a situation of family violence, and if you're experiencing family violence, in order to disclose to that healthcare professional, you have to believe that your life will be better if you open up about it than it would be if you didn't. And that's very hard. Particularly, I love what you said, that your emergency department colleague wasn't sure what happens next. So if we don't have the confidence that if we ask the question, we get an answer, we can be helpful, we can't project it. And it takes a while for someone who's in a situation of family violence to decide that they want to get out of it and they want to get help. And it's only at that point they're willing to disclose. So I view our role as opening it up for conversation, for letting people know that the world doesn't have to be that way. One of my colleagues in the emergency department asks, would you like information about services for people who are experiencing domestic violence in our community, as her opening question, because it sort of goes right to, why would you discuss it with me? And I think this is really hard. And if we don't treat the people that we're working with as individuals with their own agency, making their own calculus, then we make a lot of mistakes.
Absolutely.
That was brilliant. And I think that it puts a lot of human element to it. Exactly what you said about, like, you believe your life is, oh, sorry, I think I might have been freezing. You believe your life is going to be better if you disclose rather than if you don't. So thank you for sharing that, Dr. Sege, and thank you, Dr. Berry. And I know Diya is also coming back on the call. I think her connection dropped, but we wanted to move to participant questions. So please go ahead, feel free, and either type in the chat or raise your hand if you have a question. I know that there was a question put in the chat. I don't know, David, if you want to go ahead and ask your question out loud, feel free to unmute yourself. If not, I'm happy to read it for you. And Diya, I just wanted to give you space also if you wanted to reflect on Dr. Sege and Dr. Berry, what they had mentioned as well.
Sure. I think what they both articulated was exactly right. What I would just say, as I think working in a specialty trauma clinic, we see, sort of children who are abused, who are now adults who are being in domestic violence relationships. And we really see that tragic repetition over time of violence. And what I would say to any of you who is interested in joining this field is to work with domestic violence, is to encounter as a practitioner terrible helplessness and a sense that you are being passive while your patient is being mistreated. And that is one of the hardest things I think about our line of work. I would say we're a teaching hospital as well, and we have medical students come through and we do a lot of training. As you both have said, Dr. Berry and Dr. Sege, that we joke that, a doctor would rather do a rectal exam than to ask about domestic violence. I think that the medical students, when we teach them about inquiring about domestic violence and other forms of violence, they say, okay, we can ask, but what if they say yes, then what? And I think that is exactly the question. And I think my experience of my patients is not that doctors ask and then don't know what to do, that their experience is that doctors do not ask. Or if they disclose, that they turn back to their computer and avoid. And I think it just reflects our societal ambivalence and avoidance of violence, because we're all implicated, including us as health professionals. And that ambivalence, I think, plays out in our way of coping with it as a society. So I just wanted to add that.
Thank you so much. That was just so insightful. And we have a participant question from Joe, who is directing it to Dr. Berry. And I think this relates to what the conversation we just had, which is, how do you relay this, the quote unquote safe word in the virtual world?
Yeah, I mean, so as a psychiatrist, I have the luxury of seeing my patients on an ongoing, continuous basis. So it's never like a one-time visit. It's usually like an ongoing session. And so we've already kind of established a rapport. And so in the transitioning to the virtual world and in telemedicine, it would be like something, they actually sometimes have my cell phone number and they could just text me. We usually just have before the meeting starts, they tell me what their safe word is. I ask for it and they tell me, and so they just keep a mental check of that. And they could text me to me, or they could say it on the phone. That's how that's how I've been doing it. I don't know if other people have other thoughts about how they've been doing it too.
Just agree. I think as a psychologist, I have the privilege of seeing my patients over time. So we have developed similar ways of communicating about safety.
So just in the interest of time, there was one other question that I wanted to address to you three, as well as let you wrap up in closing thoughts. So it was talking about, I'm just going to read his question verbatim. I don't know if this is a fact, but it seems to me that most, if not all, violent people experience unsupportive and harmful parenting. If this is true, it begs the question, why aren't organizations like the CDC, the American Academy of Pediatrics, the National Alliance on Mental Illness, etc., finding ways to improve the overall quality of parenting? Would love your thoughts on this, as well as closing thoughts for the seminar.
Wow, this is almost like a setup question. I've spent a bunch of time, and many of my colleagues have, in creating responses from the American Academy of Pediatrics and somewhat less directly from the CDC about talking about parenting practices. We issued a policy statement from the CDC, from the AAP, on effective discipline to raise healthy children, that talks about using nonviolent discipline at home, why you might do that. We created materials to support that, and it was overwhelmingly supported by the 65,000 pediatricians in the American Academy of Pediatrics, and actually by quite a few members of the public. The Center for Disease Control sponsors a program called Essentials for Childhood, and they work through the state departments of health to promote societal level conditions that help parents be better parents. And the one that most people are probably familiar with is paid parental leave. That we know that when you have a baby at home or a child is ill, you may need to take time off from work. If you're poor, you can't afford for that to be unpaid. Many states have paid parental leave. This year, the federal government offered paid parental leave to its own employees, but we feel that that's a basic fundamental issue that allows parents to do what they want to do best. So there's a lot of work that's going on. It's not widely known, but check out the CDC's Essentials for Childhood and have a look.
Yeah, thank you so much, Dr. Sege, for your work. I think it's so important for us to get those messages out. And I mean, a lot of those institutions that were listed in that question have put out policy statements to talk about positive parenting. I think the difficulty is actually translating that information to the public. And that's where the divide is sometimes between science and academia and public knowledge. It doesn't always so seamlessly get down there. and so, you know, could there be PSAs that could be done that can actually reach a wider audience? And in addition, you know, I think with training, you know, what we're realizing is that you can't, it's not, in order for you to like really kind of affect change and build and develop competency, it's not so much having a didactics and being told what to do. Sometimes there needs to be an actual experience or like an act, like an event where you can actually participate and do it together. And that might be something to do in terms of like when, you know, new parents take a Lamaze class, could there be like a training on parenting and effective training and that lines. But it's also difficult, I mean, because, you know, being a parent is like, you're not just a parent for a year, you're usually a parent for 18 years. I mean, in the legal context, usually parents are parents for much longer than that, but there are developmental stages that also need different developmental responses to parenting that also need to get taught. So it's not just a one shot and you're done, it requires multiple different knowledge skills.
I completely agree. And I guess what I'm so delighted that so many people are here to be part of this, because I think it is the next generation that I feel very hopeful about. I want to encourage all of you to watch a TED Talk that Dr. Nadine Burke-Harris, who's the Surgeon General of California, did, who's an incredible person, and talked about the adverse childhood experiences scale, etc. And she said, quoting somebody who was the ex-president of the American Pediatric Society, childhood violence essentially is the biggest public health threat to our nation and our world, which is, and the lack of, she takes up, given that it is responsible for almost every form of mortality and morbidity, why are we not investing in this as a society? And I want to encourage all of you to read it and just editorialize it a bit myself, or it's my own thoughts, that I think we live in a fundamentally ambivalent society about violence. We glorify it, we support institutions that use it in every way, and the racial elements are profound in this. We're one of the few countries that still use solitary confinement against juveniles. We privatize prisons. We allow parents to beat their kids in certain states. On a national level, we have not signed on. We are one of the few countries that has not signed on to the UN Declaration of the Rights of the Child. On every level of our society, we both glorify violence and then pretend to be shocked at its effects, and then blame parents and victims for what they cannot do. And I think that is something that we are reckoning with as a nation right now. And I know you're all here because you agree. So I know I'm preaching to the choir, or preaching to the converted, I should say. I'm sorry. But I think, we serve homicide victims and then go home and unwind by watching a murder show on television. I mean, we have just such schisms within us about our approach to violence that I think we all have to take up, each and every one of us.
Wow, thank you guys so much. I know we were a little bit over, but I just wanted to close by saying thank you, all three of you, so much for your time. I love what Dr. Berry, you just said about this translation of knowledge from the experts to the public, and in some way this is what we've been trying to do, and thank you so much for participating in this. And I think what we've been trying to highlight, and what you guys have pointed out so clearly, is that while domestic violence is at its core this a very intimate thing that happens between two people, it is also not. It's about all these systemic forces that play into it, and it's from the level of the individual all the way up, and these conversations allow us to see the ways in which we can hopefully, help with this tragic issue. So thank you guys so much for being part of this. And as you guys have been speaking, we've been collecting all the different resources. And so the COVID-19 task force resources are in the chat, as well as the different resources that you guys mentioned. But thank you all so much for participating.